I think you all probably know me, but I'm a breast medical oncologist with a focus on prevention and survivorship, as well as other things. And I'm going to just talk to you a little bit about the POSITIVE trial. So POSITIVE stands for Pregnancy, Outcome, and Safety of Interrupting Therapy for Women with Endocrine Responsive Breast Cancer. And these are just some updates. I'm primarily going to talk a little bit about the trial and the baseline characteristics of the folks who went into it so that we can understand sort of what information we're going to get out of it and where there are still going to be gaps in our knowledge moving forward. So the inclusion criteria for the trial, it had a planned enrollment of 500 patients. They needed to be, that should be less than or equal to age 42, not greater than 42. With stage 1 to 3 breast cancers. They needed to be hormone receptor positive breast cancers. And they needed to have received adjuvant endocrine therapy for 18 to 30 months. This is sort of 2 years with a 6-month window on either end is how we think about it. And that could be a SERM alone tamoxifen, or it could be OS with TAM, or it could be OS with an aromatase inhibitor. And they wanted to interrupt their therapy to attempt pregnancy. And this isn't an inclusion criteria, but the primary endpoint was breast cancer-free interval. And it was really looking at the time from enrollment to the first invasive breast cancer event. So that could be local, regional, distant recurrence, or contralateral. And this is an international trial. And I am just going to say it's hard for me to monitor the chat while I'm doing this. So if you guys have questions, please do feel free to interrupt and ask them along the way. But I'll also ask for questions at the end. So this was an international trial, and you see that it spanned 4 countries, 4 continents and many countries. I just thought this picture is kind of pretty. And the general characteristics. So from December of 2014 until December of 2019, there were 518 women that were enrolled. So it was 116 institutions, 20 countries, and 4 continents. So this will have reasonable sort of diversity, and I'm glad it's an international trial. The median age was 37 years. 75% were nulliparous. And fertility preservation was used by about 52% of the women. I'm going to go into more detail so you kind of see who enrolled in the trial. So these are their cancer characteristics. It's a pretty low risk group, with 93% being stage 1 and 2. 66% were node negative. Only 33% were grade 3. But there were 26% that were HER2 positive. And I think that that's important because, that percentage is a little bit more than what we even see in the general population. And it does speak to that population. So I think it's going to be generalizable to our HER2 positive patients. Just to put this in perspective, this is a lower risk cohort than was seen in soft and text. So when we're thinking about those women that may benefit from OS and AI, this is a lower risk population than that population in general. So just in terms of the treatment they received, 45% received mastectomy. That number seems quite high to me, but I'm not sure exactly what went into that. 62% received chemotherapy. So 30% of these women, 30 plus, did not receive, 38% didn't receive chemotherapy, and 42% received tamoxifen alone. Again, sort of speaking to that being like a slightly lower risk population than maybe we see in soft and text. And then just in terms of fertility, both prior to participation and then fertility preservation that was done. prior live births. It was interesting because there was some geographical variation, and I think it's just notable. So overall, it was 75%, and that's what it was in Europe. However, higher in Asia, the Pacific and Middle East, and lower in North America. So only 70% in North America. And then regarding fertility preservations after diagnosis and prior to any therapy, I thought this was also pretty interesting that fertility preservation was done more frequently in Europe and in Asia and less often in North America. And in particular, we'll hear more later about what different options for fertility preservation include and sort of what their success rates are and other things. Fertility preservation can be done with oocyte or embryo freezing. And this is kind of, this is predominant where we see it. And part of that has to do with this being maybe the most robust mechanism of fertility preservation, and the one that is typically sort of can be supported with some insurance. And this was 32% in Europe, 34% in the US or in North America, and almost 50% in these other countries in Asia, Pacific, the Pacific, and the Middle East. And those numbers were sort of strikingly different. And I just wondered what in particular the role of insurance was on these rates, or if this was has to do with the way that medicine's practiced or provided for. Additionally, in Europe, they use a lot or a little bit more than what we see in North America and in the East in terms of using GnRH analogs during chemotherapy. Let me remind you that this was done during 2014 to 2019, and during that period of time, there was a lot of ambiguity or grayness around whether or not this was very useful. And I think that the more definitive analyses showing that there was benefit to using these analogs was done, sort of resulted at the later end of that time period. And I will say that Europe has always seemed to have a little bit more preference for GnRH analogs, as is evidenced by the fact that they did soft and we did text, just in terms of how they think about those things. So I wonder if that plays into it. And then in summary, just to say that this was an international trial of 518 women, 75% were nulliparous. Average age was 37. This was noted to be sort of on the higher end. And I think that that was called out just because I think that for our really young patients, we oftentimes complete all 5 years of treatment before we think about fertility. But this is, makes sense for this slightly older population that we would intervene earlier because, age is such a powerful effector of fertility. And then I'd say that this is, lowish risk of disease, and, whether that was self or provider selected, I think that that's interesting and something to keep in mind when we're thinking about application of this once results or as things get resulted. This is a single arm study, and it will provide information about the likelihood of pregnancy, outcomes of pregnancy, and some information about the safety regarding subsequent breast cancers. Say that it was powered for breast cancer free interval using older data, and then newer data has lower rates. And so again, we may struggle with power for this study, but I'm going to stop share there and invite people to ask any questions that they have. I can maybe start with something that Hannah asked about, which was what is offered in the trial. And truthfully, Hannah, I'm not sure what is actually offered as part of the trial in terms of assistance. I think most of what is being looked at are biomarkers for whether or not fertility occurs. So I know that they're collecting AMH and other biomarkers to better understand how that might be predictive of future pregnancy.
Yeah, no, I don't think that they're paying for it. I mean, I think we have to pay for it. You know, the patient has to pay for it through the other methods that patients pay for this stuff, which is to say, hopefully insurance. But that's not what I'm asking. What I'm saying is, how far can you go? How many cycles of, and can you use, what are the techniques that you can use? Because, you know, is this, you know, because there are different ways to do it.
Yeah, I think that it actually allows for any of that. But I think that the limitation is that you can only be off for 2 years. So that could include quick pregnancies and 2 gestations. That could include a gestation and breastfeeding. That could include 2 years of attempts without success. But that's what they're looking at, is a 2-year period off.
Okay, but the stimulation issues to sort of cause you to be able to harvest eggs and do all that, is the assumption that you would have done that before and you're going to basically implant the embryo during this 2 years, or is it you could do the whole thing?
You can do the whole thing, yeah. I mean, and I think that the idea is that truthfully, pregnancy is the highest estrogen state, right? I mean, like it doesn't really have to do, you know, you could do lots of cycles, and I don't think that we're more concerned about that than we are actually the pregnancy, because I think the pregnancy is the highest estrogen state. So I think that it allows for all of those things, and it'll be interesting to see who, you know, comes off study or gets censored because they get pregnant in the 22nd month.
Right. No, exactly. That's, I think I think both points are well taken, that there's the tincture of time and there's actually sort of what techniques you're using, and those techniques keep changing, which is why we've invited the other speaker. Yeah. Okay. But so we have had, haven't they given us some preliminary data here?
I am guessing they have, Hannah.
They send me emails all the time.
Yeah.
And it makes it just sound like everything's rosy, except I'm still worried. So tell me what you tell people off study.
Yeah, off study. I mean, so, you know, I trained with Ann Partridge. So this is truthfully what we told people before she started this study. This is how I learned to do it as a fellow, and talking about this with young women, that we typically try to get them through 2 years of treatment. You know, that is, even though we're still talking about ER positive breast cancer, that those are the 2 highest years of sort of recurrence, especially for these faster growing cancers. I tell people that I'm going to kind of model it after that when we look at the data, that pregnancy doesn't look like it increases the risk of cancer, although all of that's retrospective and there's probably confounding. And I think that, you know, lower risk women definitely are probably the ones who are attempting pregnancy, and people who are a higher risk aren't. So I go through all those caveats. And I'll, you know, for my stage 3 patients, when they tell me that they're going to have a surrogate, I'm pretty happy about that. You know, I mean, I think that.
I think this is the awkward part. Yeah.
Yeah. For those patients that are, you know, stage 3, we see that, you know, still we're not going to have a lot of data about interrupting endocrine therapy for stage 3 patients. And there's less data, there's less retrospective data. And I think that that's because we're all cautious and concerned, Hannah. So I think that that's the reason why I brought that up, just in terms of thinking about what this risk, what risk this population has, because I think it's important for us to think about that when we're extrapolating later, when these women do well, and making sure that we're not extrapolating too far. Does that make sense?
Yeah, no, exactly. I think that's really helpful. And I think, you know, you describing the population is really helpful, so we all understand what we're talking about. Because what's terrible is, you know, you meet a patient who has stage 4 disease and thinks they could take a break and get pregnant, which, you know, is just not what we're talking about here.
Right. So I would say, Rachel, thanks for you know, just going through the positive trial again. I guess of course, these are, pretty difficult, challenging conversations, and they can be. I was just wondering, like, with SCCA resources, whom do you engage kind of early on as patients start asking about pregnancy and having these conversations? I don't know if you refer them to like maternal fetal medicine or high risk OB early.
Yeah, so
maybe if you can talk a little bit about that.
Yeah, I meant to say that anyway. So when patients are talking about it, oftentimes it's been a kind of a conversation that we've started early on when they start endocrine therapy. I've known that they're interested in fertility, and I kind of put it out there. We'll talk about it after you've, completed some of your endocrine therapy. But I oftentimes talk to them about sort of what that window looks like, that I typically don't recommend longer than 2 years. And for that reason, and knowing that fertility is more difficult after breast cancer, after chemotherapy, as they've gotten older, et cetera, I usually recommend that they seek reproductive endocrinology before they even stop their endocrine therapy, to have initial conversations about what it looks like and sort of when they would think about starting treatment. And really recommend that, and I usually frame it, because a lot of people are also like, oh, I want to try naturally. And I'm like, great, try naturally and do everything else. So I kind of frame it in that and sort of way.
Yeah.
And then I tell them that I think all women who've had breast cancer should be followed by MFM. So I typically recommend that as well. It's more complicated. And, I think one of the elephants in the room is that fertility is really, because it's not covered by insurance usually, and because especially, in the rare times that it is covered by insurance, you usually have to prove 6 months of a year of infertility or trying, which isn't really an option for somebody who's, taking 2 years off of endocrine therapy. Maybe it is if that's all you can do in terms of insurance and finances, but, there's huge disparities here in terms of who's able to access these resources. And so I think that, that's out there, and it's, I think, really frustrating for all of us. And, it's just so interesting that in the Middle East, Asia, Pacific, that they had a 50% rate of embryo freezing or oocyte freezing. I just was really struck by that, because it seems like there must be some sort of institutional mechanisms that are allowing for that to happen. Anyway, and I think, would be lovely to be able to support that for all of our patients. So complicated in our medical insurance reimbursement space, but
yeah, totally agree. That remains a huge challenge. And many patients, they start the GoFundMe pages and do fundraisers for these activities. It's fairly sad that, none of these things are covered, and they know, the chemotherapy obviously is going to have a huge impact on their fertility. Yeah.
Yeah, this is tough, and it's kind of a heterogeneous situation as well. But okay, if there are other questions for Rachel, please shout out so that, but I think she's sort of given us the segue to Mary here. Mary, thank you for coming.
Yeah, of course.
This is Mary Sienkiewicz, who's a nurse practitioner with the Reproductive Endocrinology and Infertility Group at the UW. And, part of their goal with these talks is to answer the question Shweta just raised of, who do we reach out to? And Mary's one of those people that is here to help us. So I realize we're putting you in a tough spot. We've already told you that this is unaffordable for some people. But we're really, really pleased that you're here, and really want to work with you to make this go smoothly for patients when we can.
Great. Yes. Thank you. Thank you very much for having us. That was a wonderful talk beforehand, and I think a great introduction, and a similar battle we're often fighting for your patients as well, unfortunately. And also, Dr. Ryan is here with us today too, so she will also be able to jump in and answer any questions or add things that are relevant. Okay, I'm going to share my screen here.
Thank you for calling that out, and thank you, Ginny, for coming.
Hold on.
Happy to be here. That was a great talk.
Sorry, I'm having monitor decided to go off on me there. Okay. All right. In the beginning. Okay. So Dr. Ryan and I are both here today just to kind of give an overview of oncofertility treatment options we have, sort of discussions we're having with patients, and where things are headed. You know, it's a growing field pretty rapidly. One of the things that have really pushed that growth forward is first of all, survival rates among young cancer patients have been steadily increasing and over the last several decades. And also our fertility treatment options have improved. Things such as just the ability for egg freezing to be so much more successful than it used to be. And now I'll talk more about ovarian tissue cryopreservation in addition to people being able to freeze embryos. The data right now was 16.9 million cancer survivors in 2019, estimates of 26.1, and by 2040, a majority of these are past reproductive age, but about 10% are falling into a group of reproductive age patients. And also a trend just you know, of age change and when people are having their first pregnancy, you know, whereas 50 years ago, maybe 35, 38 wasn't as common for people to have been waiting. Often, especially a lot of the breast cancer patients I know that we're seeing have not had their first child. And so differences in the needs. The introduction, you know, just to talk a little bit about some of the difficulties, which I think the presentation beforehand was a great lead into a lot of the difficulties that we have. One being kind of fertility preservation, just like fertility treatments, it doesn't guarantee future fertility. And we don't have great data on success rates of things and how the different confounding factors and things that may change chances for people. We can extrapolate a lot of information from, you know, egg freezing for elective reasons or embryo freezing, but that can be difficult. Difficulty assessing the what actually infertility after treatment is and what different treatments effects will be due to both individual variability, safety of pregnancy after. Then sometimes we see patients and say, oh, your treatment won't be you know, you might not have a threat of infertility from treatments, but then maybe perhaps needing more aggressive decisions to be made. And I'll talk also a little bit more about the cost of treatment too a little bit later. So one of the first conversations, which talked about time, seems something we're very aware of talking about previously, is just the risk of time for patients is one of the first things that will kind of start the conversation out with when talking about fertility and a cancer diagnosis. This slide does a pretty good job of just kind of showing that general trend towards difficulty getting pregnant, and then if pregnant, a pretty sharp rise in miscarriage rates. And I do just want to clarify too that in talking about this, a lot of what I'm talking about is talking about being able to use one's own genetic material to carry a pregnancy, so their own eggs. There are also many treatments we can offer people if they still have a uterus, including donor eggs, or using their partner's eggs if they have a partner who was assigned female at birth that has eggs, and other ways of building family. But the difference here, especially and it's again is in the breast cancer population that I see a lot of patients I'm at least seeing, which I know is probably a small portion, and maybe those people taken out who don't have the option of payment are often in that range where a time difference of 2 to 3 years, at 24, as you mentioned earlier, 5 years is fine, and that doesn't make much of a difference. But at 38, 40, the difference of 3 years can be a real difference in chance of pregnancy. Different treatment risks. The radiation is one of the, not again something we think about with your group. Direct radiation is one of the most damaging to the ovaries, and also damage if it's directly exposure to the uterus or full body radiation. And then the chemotherapy risk is what we're often thinking about as well. And the alkylating group is one that we think is the most damaging. We think this causes follicle loss by damage in the cells of the dormant or primordial follicles, and also growing follicles. There's also some thought that vascular damage may cause damage to the blood flow and alter ovarian function, and then that also aggravates follicle loss. This is a common list that we go over with people, and I think this is a big this is where we are a place that we have so much more information to gather, and it's very hard to fully counsel patients on what exact, obviously we can't give any exact outcome, but it's hard to know what the risk of the different treatments will be. And there is part of that is because one of the things that's used often in this grouping is talking about resumption of menstrual cycles. And from a fertility perspective, we know that resumption of menstrual cycles certainly does not mean somebody is fertile. And then for very young patients, even those who have not resumed menstrual cycles, sometimes they can spontaneously ovulate and pregnancy can occur, and sometimes an unwanted pregnancy. So that measure of menstrual cycle resumption is difficult to use. Also, infertility can be transient, and a functioning ovary, as mentioned, doesn't reliably predict a pregnancy will occur. This is, we often talk about assessing for the other difficulty in assessing a fertility potential after chemotherapy is when we look at other markers, we do see this kind of decline of ovarian reserve, and that's something we talk about and look a lot at. However, the things such as FSH can vary pretty wildly over a cycle. An AMH, anti-Mullerian hormone level, or an antral follicle count, where we look at kind of that number of ovarian follicles, doesn't really predict quality or ability to get pregnant, or the likelihood of spontaneous pregnancy. So it also is not necessarily a great marker. We know it tells us, we have lots of information about what it means, and we can plug into calculators for an IVF cycle, but it doesn't necessarily tell us, again, pregnancy outcomes, which is, so I think this is where we are, and I hope for, more studies and information as we move along. Fertility preservation options that we have, so most of these are not going to apply to breast cancer patients. Pelvic radiation therapy would be moving the ovaries so they won't be in direct field. Fertility sparing surgeries for some of the gyn-onc patients. And then for patients who will be getting cytotoxic treatments would be cryopreservation of either embryos, oocytes, or ovarian tissue. And so this is just a graphic of kind of those different, so embryo banking was kind of the standard we talked about before. We talk sometimes about this being more effective. I think a little bit more of it as being more effective because we have more of the unknowns along the way of we have produced eggs and then fertilized them and grown them. And so we have more information about what we actually have. Whereas if someone freezes eggs, we don't know what the sperm quality will be, how well they'll fertilize, if they'll keep growing. but those can be frozen. Then with ovarian tissue cryopreservation, which is a really exciting thing that is still pretty new, but I think there's a lot of hope for this to be a game changer in some ways, is taking strips of the ovarian tissue and freezing it. If somebody has risk of malignancy in the ovarian tissue, then this is where I think we are lacking. We don't have that ability to really get mature eggs outside of the body, but hopefully there's a lot of research going on around that will be an option down the road. But then strips of ovarian tissue can then be reimplanted back into the body. The outside of the body maturing for breast cancer patients would be, my guess would be the more exciting piece, because the other benefit of ovarian tissue transplantation back in the body is resumption of getting the endocrine benefits. So not even the fertility benefits, but the hormone benefits, which often, you know, we're not wanting in your patient population. I'll do a brief overview of the IVF cycle. Essentially, we are mimicking all of the hormones that would be in a normal menstrual cycle and controlling those. So we give high doses of follicle stimulating hormone, which normally the brain just sends a burst of. We give injections of this to get as many of the small follicles on the ovary to grow as possible. This usually takes is a period of about 10 to 12 days. To complete the process. We start as rapidly as possible with any of our oncofertility patients. Mature eggs are collected with a needle into the ovary. Eggs are taken out, fertilized with sperm if they are freezing embryos, and we grow those embryos. Down the road, those embryos can be transplanted back into the uterus, at which point, and age isn't as much of a factor there. So people have many years then to make that decision, and a pretty quick recovery as well. We kind of talked about this. Success rates, one of the things we talk about, you know, so these are numbers that I often go over, and these are more based on not oncofertility patients. So there are some thought that these numbers may be a little lower in that population, but sort of number of eggs we would anticipate would be needed to have this kind of 50, 60, 70% chance of a live birth. So for, you know, our patients we're seeing in their late 30s to 40s, the chances of getting these kind of in one shot can be quite a bit lower. For younger patients, a lot more chance of success. However, and I'll talk a little about this later, I think just that possibility is really an important thing for a lot of patients who proceed. So some patients who have an excellent chance of having a live birth based on their age and their ovarian reserve at the time of doing IVF cycle often don't proceed, not just because of financial reasons, but just kind of feel that it's not for them as important to have genetic offspring. And others who have really a low chance are very aware of that low chance, but want that door not to be closed. I find it interesting. Often we see patients who aren't even planning to have children, but that idea that the door is maybe going to be shut for them it gives them a little bit more autonomy, especially during a time, I think, with cancer diagnosis where there's maybe not a lot of sense of control. So ovarian tissue cryopreservation, this is the only option that we have for pre-pubertal patients and for those who can't delay the start of chemotherapy. And it is no longer considered experimental, although we debate a little bit about whether the uses of it are still kind of considered experimental, but the removal is not at this point. And it theoretically is an efficient way for us, instead of just harvesting maybe, 5 to 20 eggs, of harvesting thousands of primordial follicles. And we're out of time here. And then this is, I think I have a better here. So kind of different ways then we can reuse it. So I'll go over that. This here is one is to actually put it back on the ovary. And this can then have spontaneous, people can have spontaneous pregnancy. There's a little difficulty in us being able to measure success rates of this as well too, because we don't always know was a spontaneous pregnancy from the transplantation of the ovarian tissue or spontaneous ovulation on the part of the patient. The other choice for hormone would be to do heterotopic or the underarm placement, and that would require IVF, and it's an easier transplantation. It is really low, very low use have we used where they have been able to do these heterotopic, because it does require IVF and to get that ovarian tissue to respond enough to produce follicles. There's very, very few cases of that having been successful, but it is something down the road. So these pictures of processing. So just some cool pictures from a presentation our embryologist gave, showing the processing of these are the little strips of the cortex of the ovary. They measure 5 by 10 by 1 millimeter. And they are frozen in these strips. Timeline, this just kind of shows where we are. First live birth was in 2004. Prior to that was all animal models, and now there have been more than 200 live births. And again, just another picture though of the increase in live births here. The next thing that we were talking earlier about here is this ovarian protection with the GnRH agonists. The concept being that by suppressing the ovary function, it will protect the ovary during chemotherapy. There's the science behind that somewhat questioning is that the follicles are exposed to the DNA damaging agents. These primordial follicles still are going to be affected, and they don't have hormone receptors, so in that very early stage, so it's not clear how that would help the survival. Studies are conflicting, and there goes into that, you know, a lot of the factors they use again in some of these studies would be resumption of menstrual cycles, which, as I talked about earlier, resumptions of menstrual cycles is not necessarily the best marker, but fertility and live birth rate, which is why I'm really excited to hear more about these other studies going on. So I just think we need more information on this. Breast cancer patients are where there are the studies showing the most possibility of effectiveness on it. It does have the side benefit of hormone suppression for breast cancer patients, and also patients who may have heavy bleeding or so risk of thrombocytopenia, anemias in their cycles. So something we talk about with all of our patients, usually say we just don't really know if this is beneficial or not. It may have benefit, and I don't know the percentages. I would say patients who like to do it, you all maybe would know better, but I think some people just like that idea that, well, maybe I'm doing a little something, and if it can help, that's something I would like to do. Okay. And so this is again just that how that GnRH agonist is working by downregulating and decreasing the production of FSH, LH, and estradiol. And again, there's pictures here of you have these follicles that if they're affected by the chemotherapy kind of die off. This over here on the left being the idea of how it might work and be protective. On the right here, kind of the idea that it's questionable of how it would be effective if those follicles already would have been in a dormant state regardless of the GnRH agonist. And then this is some of the ethical difficulties that we talk about. One being harm from the procedures, treatment delay, concern for exacerbation of disease for one reason or the other. The access, we talked about homogenous. We get a pretty homogenous group of patients, so we do actually wind up seeing not necessarily who's being referred, but who is able to be seen, and then who can afford. And so this is one of those kind of where I hope we're headed, is to, one, if we develop more treatments that are like, again, ovarian tissue cryopreservation, which could maybe be done very quickly with pretty minimal risk and not involving treatment delay, would be wonderful. Also would open up access to patients who don't have time. And then access, I think that it's one of the things that SCCA, I think, is now on one of your intake forms. And so Laura Lavelle, the social worker who works with me at the SCCA Onco Reproductive Clinic, has been really very proactive and working on trying to make sure anyone who might mention fertility questions or concerns is referred. Access of who can afford. Dr. Herndon, the other reproductive endocrinologist, is pretty involved in this Washington State Building Families Act, which would require health plans to provide coverage for infertility, including fertility preservation for cancer patients or others who are at risk for medically induced infertility, including gender affirming hormone therapy and other things. We also see a lot of sickle cell patients who maybe are undergoing treatments down the road. And we talked a little, it was again a great intro to us here. We talked a little bit about after treatment. Risk of recurrence of disease, risk of cardiac issues after different chemotherapy treatments, risk of surveillance, thinking about what happens if you have a recurrence during pregnancy. So as you all had mentioned, referring to maternal fetal medicine, that's also one of the other things once we see patients back or patients who come to us who've already had treatment and are talking about pregnancy is one of the first things that we will recommend. And this had a patient who was a very young patient. She was like 19. I had never watched Always Sunny in Philadelphia, but I did watch the clip from this because she would always come in and say every time she was here, she kept thinking of this from that of, can I offer you a nice egg in this trying time? It is a rather funny skit. I think we managed to finally get one egg for her. And I think that's that idea for some of these patients where even though it is very unlikely there would be a pregnancy, for her that brought this real place of brightness and hope. And it felt like quite a privilege to be a part of that with her. Dr. Ryan, anything you would add to that?
That was great. Thank you, Mary. I guess I would just encourage everybody to kind of understand, I guess, that there's increasingly access available for patients. It's improving, I feel like, all the time. We keep hearing that, the Seattle School District and then Boeing, and it's increasing all the time in the employers and that are offering fertility benefits that usually include fertility preservation, including the military, including the VA. So it seems, and it has been dire and it's still not optimal, but it's improving all the time. And then also to understand that we at UW, we offer these discounted packages for patients who are paying out of pocket and who have any sort of potential risk of gonatotoxicity or losing their fertility. So we're quite broad about that. So even, it can be rheumatologic disease that puts them at high risk of premature ovarian insufficiency, or it doesn't just have to be cancer. So we really are working hard to make sure people have access, even if they don't have coverage. So I would encourage patients, if they have any interest, to talk to us about it. And again, if despite all these efforts, they're not able to afford it, at least it's a good introduction to to sometimes the information is actually reassuring. It may be that their particular treatment regimen has not been shown, to be extremely gonatotoxic. And so I think it's definitely still worth the introductory discussion, the talk about what happens in survivorship, and then us looking into if there's any way that we can help. Because we also work with, programs, Livestrong and Walgreens and military programs to help people afford their medications and that sort of thing. So, yeah, I would just encourage us to be working on that access issue, but understand that it is improving.
Yeah, thank you for that. Yeah, and that first consult is typically covered, even for like Medicaid patients. We can bill that first visit the way that is covered, and that at least my understanding is that a lot of the kind of studies that have been done is even patients who weren't able to proceed really do appreciate getting that chance to just have a space to sit and to talk about that. And it is exciting to see more and more coverage.
Yeah, thank you for a great talk and also for your advocacy, you guys. It's just it's a huge issue for patients, and I think it's just such an emotionally charged issue. So the one thing that is covered is the GnRH agonist, and I offer that to people in some cases as also part of their treatment, right? But can you talk a little bit about this and the age of the patient? And because it seems like in the medical oncology literature, this is listed as a reasonable thing to do and a likely way to preserve fertility, or at least preserve menstrual function. But I know you guys think it's incomplete, and I feel like we're giving a different message to the patient, and it's awkward, especially since it's not expensive and it's expedient. Can we talk about that just a little bit? And I want to understand how you guys, where the data in your field is at in terms of how often that works for somebody, just for simplicity, who's under the age of 35.
Yeah, it's a hard conversation that we are having. I would say, especially for breast cancer patients, what we're saying is often that it may have benefit, and there are some studies showing the benefit, but that when we look at it, it doesn't have the outcomes necessarily we're able to use to tell you, yes, it will help preserve your fertility. When I'm talking to patients, and I'll be interested to see what Dr. Ryan says, I just always want to make sure I'm being clear that we're not presenting them as equal things, but certainly if they're unable to do if it is very, very important to them to have that chance of pregnancy, depending on the treatment type, right? So also for some of the younger breast cancer patients, they have a good chance of maybe maintaining their fertility regardless. Is that counting on that to be a real strong protector of their fertility? We don't want to be a false hope, but do feel like there is some hope, and we don't quite know which exact groups get the most benefit from it. Dr. Rand, do you want to talk a little bit more of the science and research that is?
Yeah, it's really interesting. It seems like every year at ASRM, they'll have like a debate forum, and this will be one of the debates where they have very well-informed, intelligent debater on one side debating, for it, and similar strength on the other side. And I always feel myself walking away from those things thinking, I'm still not sure which way because it is true that the idea that we're down-regulating the FSH receptors with our GnRH agonist it doesn't make sense, because those don't exist in the primordial follicles, as you well presented. So I think when you talk to a scientist, they're just like, this just doesn't seem biologically plausible. When you talk to a clinician, and they look at those, amenorrhea outcomes, then I think you see those benefits. And I mean, we are very happy. We're super happy to give Lupron to patients, because I just don't think there are many detriments to it, especially if it's covered. And it has those benefits, as you pointed out, Mary, especially for patients with, hormone receptor positive tumors. and for any irregular heavy bleeding they may have during their chemotherapy. So we are super happy to give it. We often will give it at the time of egg retrieval. So it's a nice combination of, doing the more established beneficial treatment of the egg or embryo cryopreservation, and then also the Lupron prior to chemo. I think it's true though that I can't say that, the literature is definitive. And so I certainly wouldn't want a patient to say, well, I'll do Lupron instead of egg freezing. Absolutely. And the other thing is we had a consult very recently, an inpatient consult, and she was, sort of like doing chemotherapy starting that day. And I think that question comes up too, should we do Lupron starting today if the chemotherapy is 5 days long and starting today? And so that's an interesting thing to think about, because Lupron has the flare effect, and there's some concern that you could actually worsen the impact if you're giving, if you're starting chemotherapy at the exact same time as Lupron, because you're actually exposing potentially more follicles to damage. So that's a fine point. We certainly, if we're going to do Lupron, we would want it to be a week or so before chemo starts, and we want to also usually give it with a hormone at the same time, so you can dampen that effect. Again, if appropriate, if you've got somebody with ER/PR positive cancer, then you wouldn't necessarily do that. But anyway, so there are a few subtleties to the Lupron, but yeah, that's my take on it.
Yeah, can you? We always start it early. I say 2 weeks. I know some other people think it's a month. But if you want to get the preservation from the chemotherapy, I thought it had to be, you can't just do it the day they're getting the chemotherapy. That's not going to work. I think the other question on timing is, if we're going to give them an aromatase inhibitor, when is the ovary fully blocked for that maneuver? And I don't think all this is clear.
Yeah, Jenny, I was actually going to ask sort of a follow-up question that's in that same vein, which is that you said that you give treatments, I'm not sure which word you used, to try to dampen the effect, I think, of the flare. And I guess I'm just kind of curious as to what that is, because I think that may not necessarily be contraindicated. And if that's something you would recommend, I think that this may be a good forum to just even have that conversation and think about what our standard of care is.
Yeah, Mary, what are you saying as the options for the co-treatment for the first few weeks?
So we've done, letrozole, I'll talk about with patients where we're wanting to dampen that estrogen flare from it, or that, or who are at higher risk of blood clot. I don't know that our patients, that's kind of all that I am usually talking with them about, or if they're already on like birth control pills, that's always lovely.
Yeah.
Or we're giving it after an egg retrieval, which I presume then you would get rid of that flare effect too, because we're in the luteal phase of their menstrual cycle.
Yeah, exactly. Yeah. I think that's very much the case. I think if we're doing it in, so letrozole would be our go-to almost all the time. And certainly with the hormone receptor positive cancers, but we could give like like an orthindrone, so a progestin only, or an OCP, or if they're already on an OCP. But I think with breast cancer patients, we would just go with letrozole per routine anyways. So I don't think that should be an issue, but that certainly doesn't help with the hypoestrogen symptoms that happen. So that would be more like an OCP.
Yeah, they get those anyway once we start them on chemotherapy.
Yeah.
And I think that, part of the reason, I think it's interesting to hear what you have to say about sort of the clinician and amenorrhea, because I think it was that data that kind of has pushed many of us to sort of offer it a little bit more routinely, that and the fact that soft and text were fairly positive. So anybody that we're giving chemotherapy to, we're going to probably offer OS to anyway. And so it doesn't feel so mean to give them OS before their chemo, because you're going to continue it on. And so I think those are some considerations. I think it would be great. There are occasionally patients who decline seeing you guys despite our sort of recommendations for whatever reason. And that I do offer Lupron to as obviously not as good an option, but as an option. And if you think that adding letrozole to that regimen would be effective, I think that I would be happy to prescribe that. I don't know how other oncologists on the call feel.
So we usually do what, a 10-day overlap?
Yeah.
Is anybody else doing that? Are people starting Lupron occasionally?
I haven't. I traditionally haven't, but I think with the recent data, that makes it maybe a little bit more acceptable. I recently started on it, for a patient. I don't know. Sometimes I feel like with, just adding letrozole, it sounds good, but these patients oftentimes are just, they have so much going on. Every step is, just one additional thing for them to stress about. And so, unless there's pretty good data in terms of adding letrozole, I probably personally wouldn't do it. But just one question that I did have, Mary, is I might have missed one of your, I missed it because I had to stop for a minute, but did you say in general how many eggs that you retrieve per cycle using the regimen that you use for the breast cancer patients?
I did not say that. I don't know if we have, we probably do have internal data on that. I do have, I have like charts that I can kind of go over, and I could send those on, that are charts that are kind of go over like percentage chance of getting based on age, so that we don't know that until we know they're over.
Oh, right. Yeah,
so
no, of course it's
generalization that we have from people who have done elective freezing. We do have just kind of information that we can go over with them. It often can be a little bit, cycles sometimes aren't quite as good with the cancer patients because we're just starting so quickly and they're already maybe sick and their body can be stressed. So sometimes we maybe wouldn't see the same outcome we would otherwise see in a 32-year-old with a similar, two of this.
Yeah. And I know we're short of time, but did you also say that are the stimulations different than for breast cancer patients than for standard patients?
No, the only difference would be normally we suppress the ovary briefly for most patients to sort of synchronize the follicles. And so we just, the difference is that we just start, we do what normally would be 2 months of testing and getting them ready and, education. And so to start those cycles, which may decrease the number of eggs we get a little bit, although there was an interesting article that Dr. Ryan had shared with me recently where we have all these thought processes about, well, if we start here, maybe it's a little bit better. If we start here, it's a little bit better. But for those oncology patients, it was like plus or minus an egg, I think.
Yeah, so maybe not worth
not as critical as we think.
No, because I saw you did put the chart up saying how many eggs were needed per live pregnancy, but so I didn't know how close you were to that in terms of being quote unquote successful.
Well, I think that the misunderstanding that some patients have too is that we can just make that happen. We can sort of say, well, we'll take 9 eggs for you because you're this age, and we'll take, it very much is, it is helpful to try to have a predictor tool so patients can incorporate that in their decision making and say, oh gosh, well, if it's only likely I'm going to get 1 egg, do I really want to go through all of this? But the bottom line is, if somebody decides to do that, we stimulate them as aggressively as we can safely, and we take what we can get, and then we see how much time they have and if they can afford to do it again, if they want more insurance. So we kind of take what we can get. We wish we could control how many eggs we got. But I think that's a pretty common misunderstanding. The patients come in and they ask about what's the average, and that's so variable that it can be misleading. And again, especially as you say, Mary, if you're using, like non-cancer data, it's just there's a definite effect of stress on the ovary for somebody who's actively sick, even if they're not undergoing any treatment at the time. So, and I would say too, what we always add letrozole if somebody's got a hormone responsive cancer. And we do see a really remarkable, I think that the thing that encourages us to do letrozole for the first week or two with Lupron is that we see this really remarkable response of the serum estradiol levels being very dampened, as you'd expect, but it's really remarkable. Normally in an IVF cycle, estradiols may go up to, 2000, and we see them like under 100 when you're using letrozole. So I think because we watch that and see that, it really does encourage us to know that that's a benefit as a co-treatment, both in an IVF cycle and if we're doing a Lupron to decrease the flare. So.
And that being able to go almost immediately into another cycle right after the retrieval sometimes too.
Right.
I think Dr. Ryan, you have somebody, Dr. You saw originally, who we got very little from her first cycle, and she's like 24 weeks pregnant, I think now, and just, restarted injections just a couple days after her retrieval. Who just had an embryo transfer recently.
Yeah, we've really learned a lot in our field from our cancer patients, because it's, it has pushed us to start really at any point in their cycle and to go right back to back, and to, all these things which we now understand we could do in any of our patients. But, it's been helpful and really interesting to see.
All right, I think we got to wrap it up, guys, but
thank you
so much for everybody
Yeah.
coming. I'll thank Rachel again later, but really appreciate the dialogue and your willingness to work with us and to care for this really difficult and challenging clinical situation we face, and to be our friends. Thank you.
Thank you.
And we'll be in touch.
Thank you all.